Hello, everyone. Welcome to Ease India's webinar today, titled Putting People First, the Case for Patient and Public Voices in Clinical Trials. I'm Anita Nagarajan, Chair of Ease India, and I'm very happy to welcome you all to today's session. Thank you, Ease, for supporting our regional chapter webinars, and thank you, Mary, for helping us with setting this up and with all the logistics. For Ease India's last webinar of this year, we're very pleased to host Dr. Soumitra Datta. Today, he will present and discuss findings from a study that he has worked on with several collaborators. The study, funded by Cancer Research UK and the Department of Biotechnology India, reveals insights and could also pose additional questions on patient and public involvement in cancer clinical trials. The paper associated with this study has been published by eCancer and it's free to access. We will be happy to share the link in the chat box as well. Dr. Datta, welcome and thank you for accepting our invitation. Dr. Datta is a research active clinician and consultant psychiatrist at Tata Medical Center, Kolkata in India. He leads the Department of Palliative Care and Psycho-Oncology there. He also holds an honorary dual affiliation with the UCL Institute of Clinical Trials and Methodology and is a lead reviewer with Cochrane Collaboration. In current research, he works in psycho-oncology, patient and public involvement in research, doctor-patient communication, child psychiatry, and staff mental health. We're very happy to welcome him here today, and we're honored to have him with us. A couple of notes on housekeeping. The Q&A and comments box are both available on this Zoom webinar. If you have comments and responses to some questions, you can put them in there. Any questions that you would like our speaker to address, please put them in the Q&A box. We'll keep track of them and we'll take questions whenever our speaker is available to answer them, possibly at the end of the webinar. Like Mary already said, we will share a recording of the session after the processing is over and the recording is available. All right then. Thank you, and over to you, Dr. Soumitra Datta.
Thank you so much, Anita, for that warm welcome, and thank you to Ease India for inviting me and Mary for setting everything up. I aspire to present over 35 to 40 minutes so that we have adequate time for questions. When we talk about patient and public involvement in research, we talk about why did we do the study and also briefly about the context of the study. So I do not have any conflict of interest, but I should acknowledge the study was funded by Cancer Research UK and Department of Biotechnology, Government of India. So what we will cover is briefly the history of the evolution of ethics in clinical trials and research. Why is PPI important and why does it matter? And we would also cover the findings of our particular study in India, which we did about using patient and public involvement and getting it together that what's the implication of this study. Now, if you see the broader perspective of this, why PPI is important is that all over the world, there is diminishing trust between healthcare provider and health consumers. And there is, also growth of forums where patients can speak up. So I don't think there is any option of both of us, the providers and consumers, listening to each other. At a personal level also, I think that, truth is rarely, pure and never simple. So I think it is important that as much as our truths are important, the truths which patients and clinical trial participants go through is important lessons for us. Can I ask Mary to launch the first question, please? So it says, which of the following violated ethical principles that were severely criticized later on? Single choice, so Nazi experiments on humans, the syphilis study, thalidomide tragedy, and all of the above. Okay, so majority of you have said all of the above, and that's absolutely right. So thank you. Um, I'll give you examples like historical violation of ethics. One is um, they wanted to study if pilots at high altitude, how would people react to lowered atmospheric pressure? And this was artificially done on prisoners of war. There was also a large twin study at Auschwitz where more than 500 twins had been kept together, and there were also childhood victimizations of experiment, like they were inoculated with tuberculosis, and the picture on the right hand side at the bottom shows the scars from which the lymph nodes had been harvested, and all these children were dead. Now, these are very gory pictures, and I would like to mention that, modern day Germany condemns Nazi regime and is very, very apologetic about the past. And it was, if you look at the scientific development, particularly in the field of the medicine, I come from psychiatry, a lot of good psychiatry has originated in Germany. So before the regime and after the regime, they were fantastic scientists. So please don't take this out on present modern Germany. So this is history. But what's important, the reason I mention these is that what has happened once may happen again unless we are mindful of the best interest of the research participant whom we are recruiting. Now, the tragic consequences, someone else does not go through that. What we did is some of the voices, some of the PPIs people have said may not be as tragic as mentioned in this, the slide before, but any other as well. Other than that, on a positive note, having patient and public involvement in research may help the researchers to answer questions that are relevant to the patients, and not get into a very esoteric question which doesn't matter for the patients. It also encourages having an open and transparent culture, leading to more scrutiny. You might be able to have better quality designs of a research study. So these are reasons for patient and public involvement. I'll give you an example. Before formally it was mentioned as PPI, did it happen in the past? Yes, it did. I'm speaking from Calcutta, and this is Dilip Mahalanobis, who had first pioneered the field testing of oral rehydration solution while the Bangladesh war happened. And what he had done, he had, sort of allocated one camp with a cholera epidemic to IV fluids, which was the standard of care at that time, and another camp where he had trained the family and the patients, particularly family members, to make ORS. And very famously, one of these papers was titled "A Spoonful of Sugar with a Pinch of Salt." And the family members, actually, these were trying times in the eastern border of India, and there were not enough healthcare professionals who could actually administer the ORS. So the mothers or fathers would give the ORS, and Dilip Mahalanobis showed that the mortality dropped from 30% to 4% in those who were receiving ORS. Lancet had later on called this potentially the most important medical advancement of 20th century, because even today, few million children are saved every year because of ORS. So, yes, patient and public involvement in research has been happening for a long time. If the researchers were sensitive about the context. So, have you been seriously involved? Have you previously involved patients or public in any stage of your research process? So, yes, occasionally, some of you have said, none of us have used regularly, and some of you have said that no, you haven't used patient and public involvement. Okay, so thank you, Mary. So we'll move on from this to the actual study which we do. And, in a research context, you use patient and public, so involvement may be at different levels. So one could be that you ask a patient expert to help you design the information leaflet, or you co-design it with the person. You might actually get help from them to design and consult about how the research studies are done, include them in designing the study, when should a patient be involved. And at a leadership level, you might even have them in the research team, and the data analysis, particularly qualitative data, when you're trying to make sense of each of the text context, is very, very important. So there are various levels of PPI. So involvement, partnership, consultation, and leadership. So PPI can be used in any kind of study. So systematic reviews and protocol writings, quantitative designs. So say, for example, PROMS, which means patient-rated outcome measures. If that's being designed, what are the questions that matter to the patient? Questionnaire design, even designing an intervention, that how often adolescent with depression would like to be seen by a lay counselor in the community. So these are things which it's a good idea to ask a patient or adolescent age group about the best possible way to study. And of course, we'll talk about the qualitative studies which we did. Now, our presentation today is about PPI in clinical trial design, and the paper is published, and we will send you the link. But I think, if you listen and discuss, you might have more better understanding of the situation. So democratizing value, affordable cancer care is where it started. So affordable cancer care grant, this was, you have to remember, this was in 2020 when the pandemic was just about starting. And we applied for the grant, and this was from CRUK and Department of Biotechnology. And the idea was there would be a seed grant, and after the seed grant, the main grant application would come. We did apply, but pandemic happened, it worsened. The grant actually was not dispersed, the main grant, it was withdrawn. But luckily, the designs from the seed grant, when we designed our study on PPI, it was self-contained, and we could publish the first paper recently about how a trial should be done, even if the main grant did not happen. And the focus was that initially we were thinking that this PPI would complement the trial design and fine-tune the methodology and ask patients' views in regards how the design, recruitment, etc. should be. And we did that irrespective the grant happened or not. So, perception of cancer clinical trials, we explored amongst patients and public, views on recruitment to clinical trials, patient education materials. And, because originally this was planned for immunotherapy in head and neck cancers, we also explored about the perception of novel cancer treatments and participation in such a trial. Now, if you look at patients, they have their life experience of going through cancer. The clinicians have the experience of being clinicians, and the researchers, we did it together with the Institute of Clinical Trials of University College London and the trialists in UCL. They run some of the largest trials in the world today. So this was quite a cohort group which we could, learn from each other. The recruitment for the study, it was a qualitative purpose of sampling, and we stuck to adults and their caregivers and lay public, and we also included professionals. In today's presentation, I won't be talking much about the professional aspect of it because the presentation is on PPI, but if you go through the actual paper, you'll see the perspective of the professionals as well, but it's separately given in a table as opposed to patients and public, so that people don't get confused between the opinions. The sampling, in order to get members of the research study such that in a cross-sectional study you get a longitudinal feel, if you can get some patients who are very early on in their cancer journey, say around the time of diagnosis, include some patients who are getting active treatment, and include some patients who are cancer survivors who have completed treatment. And we did the same for their caregivers as well. And members of the public were school and college principals or HR professionals who had something to do with a large number of other people whom they managed, and even other members of the public as well. The professionals included trialists, ethics committee members, people involved in research governance exercise, trial coordinators who were chasing the patients, ensuring that they come for the next visit. So you can see there is triangulation of looking at the same problem from various different viewpoints. And we did in-depth interviews and questionnaires. We got a feedback from the professionals initially to understand what are the issues which should be explored, and we got some feedback from some patient representatives as well. All interviews were video recorded and transcribed and analyzed using the in vivo software. So if you see the sample, majority of the patients were women. So we wanted to make sure that both genders are represented as regards patients and caregivers. Public, again, it's 60-40. Professionals sort of reflects the gender distribution in an oncology center in India, and a majority are men. And we ensured that all the common cancers like breast, gynecological, say cervical cancer, head and neck, genitourinary cancer, lung cancer, these are represented in our study. So these were small numbers, but we purposefully chose patients such that they're representative of the Indian cancer population. Now, what were the themes? So we used the methodology of qualitative content analysis, which is one of the ways of looking at a large amount of data. You make a coding framework from the first few interviews being analyzed, and then try to fit in the subsequent interviews into the themes that have come out. So what was the first theme? The first theme was perception of clinical trials. So, some people did have an understanding about what a clinical trial is. And, if you think about the time, 2020, that time, this was a time when, lots of vaccine trials were going on and medication trials for COVID pandemic was going on. So I think people had a better idea about what a clinical trial is. And as you can see, this member of public who had mentioned that I understand it is a work in progress, and therefore, if I'm part of the clinical trial, they will use my system, my physical system, to check the test results of the pill that they're testing, the bad effects and good. I think this is quite a good, mature understanding of the trial, but this was minority. The other parts of people who did not, but if you explain what a trial is, most of them could follow. And so it's important that even if a person doesn't know what a trial is, but if the PI's representatives, while recruiting the patients, explain to them what the trial is, most people are able to follow. And they were willing to be randomized, attend the trial related additional monitoring visits, and all that is entailed in a trial. Now, we also, explored about the second theme was regarding recruitment to a clinical trial, because these were often clinical trials are from volunteers. And there was a consensus that trial discussions should be with the patient, with the caregivers and the family included. However, so in a country like India, patients trust their family members. However, not at the cost of excluding the patient. I think that's very, very crucial. So keeping the patient at the center is very, very important, and not have the discussion with just the family members. See, I feel the priority must be given to the patient. I would want my family to understand it, but I should first be told about this, what I am about to go through. So this is a patient who talked about that. So I think, that's an important message from this paper, if you may consider that, patients in our country wants to know about it. Many of them preferred that there might be necessary for multiple discussions, not just one discussion and one signature. So I feel priority must always be given to the patient, and I would want my family to understand, but I should be the first to understand what I am going through, and multiple conversations are needed. While recruiting patients, Tata Medical Center, where this study, a lot of the patients were recruited from, is in eastern India, and we treat patients from the easternmost states like Manipur, Nagaland, Assam. We treat patients from Orissa, Jharkhand. We also have international patients from Bangladesh, Nepal, and Bhutan quite frequently. However, patients and caregivers felt that if it's a clinical trial and you are expecting the patient to come and visit several times, you do need to recruit more of local patients because they need to be able to come to the hospital if there is any need or side effects. So, focus on local patients. And I think this was very, very insightful while designing a trial, because if you randomize someone and then you cannot follow up, that becomes a problem when you are trying to write up the paper, lost to follow up and things like that, and writing and the statistics, everything gets complicated. The benefits of written information. We talked about patient information. So we talked about audiovisual information and written information. So most people wanted simple information written in leaflets in vernacular languages that is accessible and understandable to patients in that part of the country. So in Kolkata, it probably would be Bangla and Hindi. But we also explored about audiovisual information, and we had answers which were positive and negative, which is interesting. So some patients said that doctors are not actors. So if you have a PDF or a patient information material printed, I would expect that 5 or 7 doctors would have got together and they have printed, seen a few drafts, and got something ready which is more accurate and precise. Whereas in a video, you can only listen to one person's views. Also, somebody said that in a PDF, you could search only that part which is necessary. Now, that's not technically exactly right, because nowadays you can have signposted videos as well. But I guess the message here is, yes, audiovisuals have that advantage of people who cannot read to actually listen to the videos, but please also have a written information material which is printed. So I think having both is the best way forward. Now, we talked about beneficial and adverse events, about the pros and cons. And, in terms of pros, often cancer clinical trials talk about trials such that it tells you how much reduction in the possible rates of relapse is. Now, personalizing a median to somebody once yourself is quite complex. To give you an example, if somebody asks, how long would I live? The person is asking about himself. They are not asking about the median survival. So similarly, this was quite insightful that one of the patients had said that people don't think in terms of benefits as measurable and a percentage. I think if people actually explain it to them, that's probably better. So that's very, very interesting. I think we in today's world, you cannot not give the quantity, but at the same time, explaining it, what it means to an average person who has been recruited, should also be explained. As trialists, we wanted to explore, because this trial was planned on patients who would have otherwise had a curable cancer and then receive NSCT, and after the standard treatment was over, they would get the additional treatment of this proposed trial. But unfortunately, even the experimental agent could very, very, very rarely have fatality. So you are talking about a patient who would otherwise probably would have lived, because of participating in the trial, may die as a side effect of the medication. And we wanted to ask that what was the patient's views about discussing death as a potential side effect. And patients said that I would appreciate if things were explained to me individually as a person, and I needed to be explained all the pros and cons. There were divided views for family members. Some people said that patients would get scared, but I think it's very, very crucial to understand that patients actually wanted to be told. And some of them also felt that anyway, I have a very serious disease, so I know that there is a possibility of me dying. But if I am told about this, I would feel probably, have more trust than suddenly finding myself very sick. So, benefits of discussing the potential pros and cons of participating in the trial is very crucial. The last theme which came was about consent, and um, the consent discussion, patients and public said that it's important that uh, the doctors mention the truth, the whole truth. And in India, often consent, there is a people talked about the imbalance of power between the service providers and the service users. And often this actually may backfire because, as you can see in this quote, that some patients might rely and not be able to comprehend that the experimental treatment is not a proved treatment, and hence there is a trial, and the experimental treatment also can do harm. So we should go an extra mile to explain that. And in India, most patients felt that they would want the family members to be present while they are consenting. And this is very different from probably the West. And they would be more reassured if they took the decision collectively after discussing with the family. But obviously, they wanted their views, patients wanted their views to be heard first, and they would make the first decision to participate or not. So these were the 5 themes that we had, and you could reread them in the papers. Now, we feel that who would benefit from this is, healthcare researchers. Of course, patients would benefit because they would have more trust and faith when participating in the trial, and healthcare researchers, the people who design the trial, service managers, so that things are more attuned to a more healthy patient care delivery. And the public also felt that this would reduce the imbalance of power a little bit. So I think if you have PPI, everybody benefits. Now, what are the barriers of PPI? Some of you have answered that question already in question 3 and 4. So, feeling threatened, researchers, sometimes we may even think about, having dumbing downs of science of healthcare. And large organizations may serve the outside world they rarely interact with. So, I think this is one of the times when it reminds us that those of us who are in academics, we do need to get down from the ivory tower and interact with the people who for whom all this research and clinical services are being made. The provisions, and we need to start thinking about PPI from the very beginning, because it helps in designing the trial. So we asked patients, when do you think we should inform the patients about the possible trial after the standard treatment is over? And this was very interesting, because they said that don't tell me at the very beginning, because at that time I probably am very overwhelmed with the diagnosis of cancer. Neither should I be informed at the very end when the standard treatment has been over. So CTRT in mucosal cancers, so it goes on for 6 months. The patient might go have radiotherapy and concomitant chemotherapy. And after 6 months of treatment, when the person is thinking that, well, yes, next month is my last treatment, and after that, if they're informed about a potential trial, you are not psychologically ready for participation. Whereas, while you have engaged in the CTRT, at that time, say after the 3rd cycle of chemotherapy, if you tell, well, there's a possibility of you participating in a additional clinical trial after the end of the standard treatment, I think at that time, I'm still engaged in the process of the treatment, and I might psychologically prepare for the additional monitoring visits of 6 months, once a month, after the standard treatment is over to get the immunotherapy. So I think so that is very, very important when you are doing actually a trial with this kind of population. So I think everybody benefits. You identify the resources, you build a team of PPI. The patients should be, the desirable attributes of patients should be patients who have an experience of the clinical condition, and they should be having a direct care experience if it's a carer, not by proxy. Sometimes, people who give a complaint or feedback about a service, they have unique experiences as well. So they might be desirable members of the patient community or carers. And public could be, general caring experience or, media representation of services. These are people who might be good members of public who would benefit, who you would benefit from including in a PPI. When you're training people for PPI, you won't be able to become an expert on day one. So you need to, need to have resources for training in PPI and training researchers as well to understand how to listen to other people's point of view, manage, their own fears of failure and understanding self. Because, it's like family therapy here. So two parties who are skeptic of each other are trying to build a bridge. So watching someone else doing it while it's a patient representative, they are seeing somebody else in another trial where the patient representative actually positively contributes while analyzing the data, having informal meetings and training events. These are all useful ways to build the bridge. And the interactions could be online, face to face, or through newsletters, notice board. And I think probably best if all these mediums are used. I won't go into the questions because I think many of you have seen the questions already. I would like to conclude that the ethics of clinical trials has evolved over the past 100 years or more, and patient and public involvement is crucial today. So, patients and public in low and middle income countries where a large number of trials are conducted now, they do have their views, and we need to work together at every step of the process. So, I would like to acknowledge all the research participants, patients, carers, public, and professionals who were kind with the time to give us their views. The senior researchers in UCL, Professor Usha Menon and Professor Duncan Gilbert, they were sources of immense support during the entire process of research. The entire research team, I am very grateful. The pictures you saw is by a professional illustrator called Rajendrani. She is a psychologist but also helps out with all our illustrations. She is quite famous in the eastern part of India. And of course, I cannot mention enough the funders for this research, because this is not something which is usually done, but CRUK and DBT were very, very gracious to continue the funding even while the pandemic had started in the first wave. If you're interested in our work, if you get this QR code, the website called artofmedicine.in, many of our research on various aspects of psychological and social aspects of health are there in the website. There are talks, so you're welcome to visit that. With that note, I would like to take any questions you might have, and I'll hand this over to Anita again.
Thank you, Dr. Datta, for an excellent presentation. We have one question in the chat right now, and I'll read it out to you. Prita Paul asks, what stayed with me from the paper is the fact that socio-economically impoverished patients and families agree to participate in trials despite potential risks so that they can access free of cost drugs. How do we circumvent such a power imbalance?
Yes, I think it's a very good point, Pritha. So, if somebody has ran out of options and you are coerced that only thing you could do for your elderly relative is participate in a trial, that is coercion, that is not consent. So I think what we need to do is, so there are two parts to it, that medicine needs to be more affordable and accessible, but that's may not be in one individual's hand. So there are initiatives, say like the Prime Minister's es- list for essential medicines and things like that, which are uh, aimed at better access, or even insurance schemes which actually helps people to access cancer care. There are India is a large country, so there are very big centers which give very subsidized treatment. So All India Institute of Medical Science, so 30 fractions of radiation therapy for cervical cancer costs only 700 rupees. So these are some things which can be done. But if they are being recruited to a trial, you need to acknowledge that this is a vulnerable group. And I believe if the trialists and the team is willing to communicate, people would understand and take extra time to communicate. This is where it is, and it's an experimental treatment. It has not been proved. That's why the trial is being done. It doesn't guarantee that the outcome will improve. We don't know it. That's the way why it is done. I was talking to someone regarding this point in Australia and US, and people said that this is not unique to India. So lots of people who do not have insurance, even in high income countries, often feel trial is a solution in the stage 4 cancer. So I think this power imbalance is a very crucial area, and if we are aware of it, we'll probably try to bridge the gap.
Thank you, Dr. Datta. I have a question. So, in your opinion, from your study, from this study and other research that you have done so far, what do you think are some key differences in PPI in countries like India, other middle income countries, and maybe other more developed economies and countries? What are the key things that distinguish PPI in these two?
Yeah, I think, in the West, overall, the outcome of cancer is better. So there is a published Lancet Oncology paper by Dr. Mohandas, who used to work here. So in 2014, he had shown that in India, 60% of cancer patients die within the first 5 years of diagnosis. Now, that's obviously not the case if you are getting treatment completely funded by the government in UK, say NHS. And so in UK, when you do PPI, you might get patients and public representatives who have gone through this cancer treatment and after 5, 7 years of survival. Whereas in India, you might get people who have been through this experience much not that long ago. So I think that's one difference, because an experience which somebody has gone through it and has matured and is willing to contribute versus somebody who is actively going through the treatment, they may have slightly different views. The other aspect of it is, I'll talk about my dad. So I think uh, we are a culture where often, uh, if you think in terms of growing up, uh, your parents did not want your views, darling. What do you want to have? You were told what to have. So I think, and in medicine, where there is often an infantilization, very similar. So patients are vulnerable, and doctors and medical health systems make decisions for them. So I think this imbalance of power is changing fast with the patient advocacy groups, online medium, people posting about their experience, Google review. So you like it or not, democratizing is happening. I'm an optimistic person, being a psychiatrist. But if, as professionals and researchers, we are not there yet, it may come as a shock. So I think these are two crucial aspects of difference.
Thank you, thank you. And the next one, there is a question from Mary. And Mary asks whether the number of participants in this study is typical for this type of study? How much can we extrapolate from this, and could this be extended
Yes.
to more participants so that we have something more What are your thoughts on that, Dr. Datta?
Yes, I think it's a very good question. So this is a qualitative study. So usually, if a qualitative study, the idea is you don't select participants randomly. You select participants through purposive sampling such that people are able to express their views and they're articulate and they can talk about it. And if the interviews are done well, usually research shows that by 25 and 30 patients participants, usually you get the same themes being repeated. Now, having said that, we have done studies with more than 100 patients doing qualitative interviews, but I think after a point, having a lot of interviews but having the same information doesn't make sense. So the way to follow this up would be that if you design a questionnaire based on what the views the people have expected in these 40 interviews we have had, 41, and then you could do it on a larger number of patients and public, so get 300, but 300 qualitative interviews usually is not done. So I would say that this is one of the average number of patients we are included in a qualitative study for any part of the world. So some people do, we had 41, some people publish even with 25, and there are people who publish with 60, 70 interviews. So that's where we are. We're somewhere in the middle ground.
And I think Mary has a follow-up question. When you included patients in the study, how did you capture the patient's lived experience? How much weight was assigned to that?
Yeah, meaning I guess it is about the patient's lived experience. That's the most important part that we are trying to explore. In terms of in a you know when you talk of weight or a weighted average, it's a quantitative concept. So quantifying quality is in some way an oxymoron. So in qualitative studies, you what we could do, so somebody has given an answer. The next patient you recruit or who is you are interviewing, you could actually ask them, what do you think about videos which was mentioned by some other people, and then maybe explore that a bit more further. So the themes which come in the initial few interviews, if they if you have to analyze the data side by side with the interviewing going on. So you don't wait till all the interviews are over and then start analyzing. So you go into more depths of things which you think is worth understanding and exploring more. Now, the caregiver experience, see, in oncology, even in the West, if you are diagnosed with cancer, say in London, I was a consultant in King's College Hospital, and you would usually come in the initial few visits with a friend or a family member. So I think getting the carer's perspective is also crucial. Um, so uh, the lived experience of a caregiver is slightly different from the lived experience of a patient, but I think we live in human society where we sort of depend on each other. And if there is no caregiver, I don't think it's easy to do a trial. So I think both their experiences are important. What is less important is the views of professionals often, because they may have certain experiences based on their unique life situations, which people would often want to impose on what they believe patients want. I always believe the best way to get nearer to the truth is by asking. So, when we started psycho-oncology in Tata Medical Center many years ago, lots of people said that, breaking bad news and knowing about the cancer diagnosis is something which is very Western and our patients don't. And I had my doubts that that's probably not true. And we have published several papers on that our patients also want to know. They may have different questions. So some people may want to know every step of the treatment, what the surgery would entail. Some patients might want to know what will happen at the end and what would be the most difficult thing they know. People want to know the bad news more than good. So I think having practiced as a psychiatrist in south of India, then Scotland, then Manchester, then London, and back in Kolkata, I have great faith that human beings have more commonality than differences. So that's my take on this.
Hi. Thank you for your response. And we have one more question in the Q&A. Prasida Menon asks, she says, you mentioned that all the interviews were recorded. Did you face issues with consent for video recording, as there will always be a mix of participants who are both comfortable and uncomfortable on camera? If yes, how did you handle consent from those who were uncomfortable?
Oh, very good question. And excellent. We did face issues. So I am very a stickler for the IRB and the consenting process. So we had a signed consent form signed by the patient. So we would send the information leaflet about exactly what will happen, and then we would get the signed consent form before we'd go through the interview. So you don't sign the consent and immediately start giving the interview. So there might be 10 days, 15 days gap in between. um, Surprisingly, patients did not have much of an issue regarding video recording. Our importance was mainly we would want to get audio recording, but we did have one or two professionals who said that I would, because of all this fear of, like videos being morphed and changed. So I remember a particular professional was very happy to be part of the study, but requested us to have only the audio recording without the camera being turned on. And I was happy about that. We wanted her views, even if we are. So if you see somebody like you are seeing us now, usually there is a better connect. But if somebody doesn't want that and you know that person, that's fine. So we would just go with audio interviews. We did not, archive the video recordings at all. So we just archive the audio recordings because that's what usually is done. And so that's actually a very relevant point.
Thank
This
you.
was done face to face with the patient. There was no video recording. We just had the audio recording on an audio recording device.
Thank you, Prasida. I hope that answers your question. Okay, we have one more question for you now. Thank you for this informative. Tawfiq says, thank you for this informative talk, doctor. My brother died of lung cancer in November 2024 at the age of 62 in the US. His second set of chemo was stopped when it showed on showing ineffective. He tried to join 2 or 3 trials of new medicines, but was never enrolled. How does selection take place?
Yeah, I'm sorry to hear about Tawfiq, your experience, and I hope you get over the loss of your brother, whom surely that you loved and cared so much for. So each trial has its own eligibility criteria. So it would depend on the person's age, may not be age in adult population, but more about their stage of cancer and the type of cancer they have, because different cancers have different medications. Even the same lung cancer may have different subtypes of histopathology. So that's one question. And the other reason why you get selected for a trial or you are invited for a trial is the performance status, which means, is that person fit enough to, receive experimental treatment, which is about performance status means that often if you look at it in a lay way, that is the person able to walk into the hospital by themselves. So there are different ways to classify it. There is the ECOG rating scale. So these are ways of doing it. Now, I don't know if this will be any consolation. There is data in lung cancer sometimes that good quality palliative care often may be beneficial for the patient's quality of life and survival than an experimental treatment. And this study was particularly done on lung cancer. So yes, you are someone who loved your brother and would have wanted him to get everything possible, and that's absolutely fine. That shows that you love him. But the trialists and the doctors who considered him to be part of it but then didn't enroll them may have their own reasons for it, and it isn't necessarily negative that he didn't participate. You were there for him in the last stages of the disease. So I think you know it's complicated sometimes that people have all the faith on the trial but they aren't able to join. But usually it's for the benefit of the patient. Yeah, this war medicine, the war rhetoric, I don't use much. But in US, you would see 1970s, the president signing war against cancer. But I think, it it dehumanizes it. So I don't use that particular words, but obviously this was probably a medicine which they were worried about. I can't answer specifically for your brother, and I'm a humble psychiatrist, so I'm not an oncologist. So I have limitations, but uh, you know, look after yourself, I would say, and whoever is there today.
Thank you, Dr. Datta. I have a couple more questions, but I'm going to wait to see if anybody else in the audience has questions before I ask you whatever I'm thinking of. If there's any questions, please post them. We may have time for just one more question before we end our webinar today. And since I don't see one, I'm going to pose this question to you, Dr. Datta. So I'm wondering about the communication material that you talked about, the handouts and the videos and other forms of other formats. Is there any training best practices published for how this communication material can be developed effectively, especially since it goes out to a wide range of audiences? It's perhaps something for the patients. Is it different for the patients, different for their caregivers, for others involved, or is it the same? And do you have links to any best practices? Are there any trainings available for this kind of communication?
Viewpoint, Anita, I myself think that this is very, very crucial that we develop ways to train trial teams to develop better communication material. I think there are some standards of how communication material can be done, but they're again mostly from high income countries. Our next study, actually, which is a follow up from the current study, is that we want to get specific feedbacks about a trial related video, like 2 minutes video, and a trial related leaflet, and get the views of patients, public, and professionals on that. So hopefully, in a year's time or 1.5 years' time, we would have better answers for that. But I think while we do this, we should start thinking. Maybe ease is one area where Ease India could do is collaborate and offer training courses for developing patient information material. So I think there's this. I think I do think this will happen, but we could take it up.
Okay. All right. Thank you for that, and we'll definitely explore that. Taufik has a clarification by War Medicine. I refer to the practice where the old are not taken into consideration. Do you have any last comments on that, Dr. Datta? After that, I think we will close the webinar. Please.
age is a number, and cancer often affects the elderly. So say for breast cancer, a median age is 52. I used to think that as old, but after I turned myself 50, I think that's very young. So I guess uh, I don't have a straightforward answer for that. It depends on the cancer. So prostate cancer happens often in much older age group. So trials have different age groups, which would be this thing. But I think more than age, it is about the performance status. Somebody who is robust versus someone. See, cancer is a disease where your own body cells are multiplying very fast. So the treatment against that is actually killing some of your own body cells, which is the part of the cancer growth. So the side effects of cancer treatments are much more serious than other treatments. So, say malaria or viral fever, they're targeted at the virus or the malarial germ. Whereas in cancer, it's against your own body cells. So people lose hair, lose appetite, have nausea. So you need a certain amount of being able to endure that, and no trialist would want the patient to fall more sick than what he would have if he had not participated in the trial. So that's my closing remark.
Thank you. And we have a comment from Prasida saying training sessions on co-creating patient information material with patients and caregivers will be very helpful. Thank you, Prasida, and we will see what we can do. We will explore that further, and thank you for your questions. So with that, we come to the end of the webinar. Thank you very much, Dr. Datta, for accepting our invitation and for your excellent thought-provoking presentation today. Grateful to everyone in the audience today for participating in this conversation and for posing thoughtful questions. Thank you, Mary, for all your help. I know you're in the background, but you've helped us a lot set this up. To everyone here, you will receive a link to the recording of the session via email soon. And we look forward to seeing you again at another event from EASE or EASE India. Thank you very much, and bye-bye.
Thank you.
Thank you.
Have a good weekend.
Thank you, everyone. Bye-bye.